Welcome to the I Can See Clearly Now, Good Experiences and Great Health Outcomes through Effective Cultural Safe Primary Healthcare webinar series, and the third webinar and the final webinar in the series, which focuses on the quality health checks and ongoing primary healthcare. We recognise the traditional custodians of the lands and seas on which we live and work, and we pay our respect to elders past and present. And today, like with the other two webinars, we are joined by Mary Belfrage, Medical Advisor for the RACGP NACHO Partnership Project and General Practitioner. Mary has been a medical practitioner for 30 years. She has worked as a GP in community health and in Aboriginal community setting in both desert Aboriginal communities. And from 2009 to 2017 as the Medical Director at the Victorian Aboriginal Health Services in Melbourne. Mary has been involved for many years in teaching medical students and GP registrars about working effectively with Aboriginal patients and communities. She has also been involved in numerous research projects and held policy and clinical advisory roles in wide-ranging areas, including primary care, population health, effectiveness and acceptability of models of healthcare, and safety and quality of healthcare. Mary was also an author of a chapter in the latest edition of the National Guide to Preventative Health Assessment for Aboriginal and Torres Strait Islander Health, and was a clinical lead on the RACGP NACHO project to review and develop new recommendations for the MBS Item 715 Annual Health Check for Aboriginal and Torres Strait Islander people. We are also very lucky to have Jacinta McKenzie join us. Jacinta is the Integrated Team Care Supervisor and Indigenous Health Project Officer with Wellness Our Way at Country and Outback Health. Jacinta has significant experience working across many communities, primarily working on complementary projects to support collaborations in the Aboriginal primary healthcare and mainstream GP practices. She has been a project group member of the NACHO and RACGP reference group to support implementing the National Guide and support mainstream general practices to deliver culturally targeted and responsive healthcare for Aboriginal and Torres Strait Islander people. And she is also a member of the 715 Aboriginal Health Assessment Project Working Group. As a leader, Jacinta has a vision to inspire her community to motivate change and support culturally safe practices, and is determined to build partnerships that support equality and good healthcare outcomes. Jacinta's vision is to embed cultural safety by strengthening the pathways from the patient-centred care perspective and explore the strengths of integrating cultural mentorship to care planning and follow-up care in the community. And as always, third but not last but not the least, Ms. Ada Parry. Ada is the Cultural and Education Advisor with the RACGP Faculty of Aboriginal and Torres Strait Islander Health. Ada is a Brinkin woman, a grandmother of 12, and her languages are Marathil and Nangingurungu. Ada has a long-standing relationship with the RACGP from being a cultural educator of both medical students and GP registrars from 1996 to 2000, and a community representative on the RACGP Aboriginal and Torres Strait Islander Health Faculty Council in 2015. In 2018, Ada took on the role of Cultural and Education Advisor with the RACGP Faculty of Aboriginal and Torres Strait Islander Health, and is heavily involved in all areas of operation, ranging from education and training and policy and advocacy. And now, Dr. Mary Belfrage will start the webinar. Thank you, Mary.
Thanks, Daniela, and welcome everyone. This is our third and final webinar in the series about providing culturally responsive primary healthcare for Aboriginal and Torres Strait Islander people. And you can see these are our themes for tonight. We're focusing on health checks, what makes them a useful activity in general practice and where they fit in the rest of primary care, what makes them worth doing for Aboriginal and Torres Strait Islander people. And in breaking news, following endorsement of the new recommendations for the health checks, we're excited to be able to share the new templates, which are available on the website as from yesterday. So we'll be having a look at them in a little while. In preparation for tonight, we were reflecting on some of the broader context of our work firstly COVID, specifically the transition to telehealth as a major way GP consultations are being provided at the moment. And we acknowledge that the health check has been included as a telehealth item, but we won't specifically be discussing telehealth issues tonight. But we also wanted to acknowledge the Black Lives Matter movement and the re-emergence in Australian public discourse, the conversation about incarceration rates of Aboriginal and Torres Strait Islander peoples, and the failure to implement any of the recommendations of the Royal Commission into Black Deaths in Custody that was conducted, I think, from 1987 to 1991. And just really to say that we recognise, and supported by a lot of evidence, that racism is really bad for your health. Thinking about health checks, so legitimate first question is why we do them, and we do them to improve, hopefully, individual and population health outcomes for people. They can be really effective as both an initial supporting engagement initially and in an ongoing way in healthcare. They started in 1999 in Australia with adults and have gradually evolved to include all ages. I think the possibilities are that health checks are a way of embedding a systematic approach to providing health promotion and disease prevention, to early diagnosis and to tracking chronic disease management. They can provide evidence-based checks on elements of healthcare and prompts for health information, risk assessment and other services for primary and secondary disease prevention. Again, it's a systematic way of building in identification of patient health goals and priorities, and they can support health planning and coordination. I think another valuable use is to check in on people's participation in established population health programs like immunisation and cancer screening, developmental tracking for littlies, the cycles of care that are sort of part of our standard model of care in primary care, and lots of other services like oral health. They also have become an important part of funding access to other elements of primary health care, particularly allied health and Aboriginal health worker and health practitioner and practice nurse follow-up. And they've become a really major part of health policy in primary care for Aboriginal and Torres Strait Islander people, and there's an explicit commitment with some targets around health checks in all the sort of major policy documents now in planning for Aboriginal and Torres Strait Islander health. So there's a whole lot of promise in health checks. Then there's a whole lot of things that need to be in place. Next slide, thanks, Daniela. That make a health check worth doing, but these are some of the elements that will make it worth doing. I'm likely to support it to be actually supporting good health outcomes for people. So, and we'll talk more about each of these elements through the webinar, but that they're really patient-centred, and that includes being culturally safe. And that's from all our sort of feedback from people, and the evidence is much more likely to make it a positive and useful experience for the patient. That there's a commitment to patient priorities and goals. There's a few elements that are about continuity of care, that it's provided by the usual GP and team, and that of course is a requirement for MBS reimbursement, but in practice it's not always what's followed, and we'll talk about some examples of that in a little bit. The other part of continuity of care is, of course, that there's follow-up. A health check on its own is unlikely to be of any benefit other than the remuneration that the practice might get, but of no health benefit. So that the sort of follow-up that's really important is that there is evidence-based treatment of conditions that are identified, that there are referrals and recalls and that are put in place, that the information that's provided in the health check is appropriate and accessible, and that means that the patient needs to understand what the information is. So it needs to be, for it to be useful for them, to be at the right level, appropriate to the level of health literacy, in the right language, and that it reflects ways of thinking and knowing that are real for the patient. Referrals need to be accessible and appropriate and affordable, and the purpose needs to be understood. I think that element about checking understanding as a non-Indigenous clinician, it's always important for us as clinicians. As a non-Indigenous GP who's worked for many years in Aboriginal communities, that's a really key part of the of ensuring that the whole activity is useful and that people are likely to follow up or follow advice and information that's shared in the process. Okay. I'm going to hand over to Jay to talk about some of the things that are valuable to the patient. Thanks, Jay.
Thank you, Mary. So when we're looking at respectful, culturally safe experiences for Aboriginal and Torres Strait Islander people, we need to consider holistic health in their healthcare journey. So we need to look at what was important. So if we're looking at Jenny's case, and for those who weren't part of that session, there were a lot of complex issues that Jenny had faced. And one of them that was identified through the process is the disconnection from culture. Not only that, she had mental health issues, which affected her decision making. So she couldn't make choices in regards to where she was seeking good healthcare. And we had to look at different ways of working. So in Jenny's story, we had to look at the priority areas and what was relevant for Jenny. And we had to look at what was cultural appropriate services that was going to engage Jenny in a way that suits her well-being. Her mental health was really unstable at that time when we engaged her, but we need to look at the different pathways and see where we could link her in to make sure that she was supported appropriately. Jenny wasn't part of a healthcare system. She was quite isolated within the community, and we need to look deeper into her story in regards to how do we build the stronger partnerships to make sure that if she is going to seek care, that the GP and Jenny had to be part of the solution. Jenny led her choices, which was really good. There was a two-way engagement, which was important to her care, and we had to make sure that we acknowledged that there was a trust between the GP and Jenny in order for Jenny to move forward. So the initial engagement with Jenny was around her health check, so the 715, and starting off with different stages of the 715 because we didn't want Jenny to be dumped with a whole heap of information that she didn't understand. So in Jenny's case, it was about building her health literacy, making sure that she understood every step of the way, so it wasn't just a completed 15-minute assessment. It was looking at her health comprehensively and making sure that it was a quality health check and not just a tick box and hope you are feeling okay. So we had to dig a little bit deeper in regards to, supporting Jenny's journey. And it took a lot of hard work and persistent, but there was a lot of proactive approaches which come from all different directions. So from the specialist point of view, from the clinician and GP's point of view, the practice nurse had their perspective, but Jenny had the choice and the choice was in her hands. So with Jenny's story, she went from very complex health issues to feeling understood. And that's why we provide the culturally safe healthcare that we need to provide, so that they're not falling through the gap in the healthcare system, that they're navigating all areas of care. So if we're looking at health and wellbeing and improving that, then we need to acknowledge where the patient is at. We also need to be mindful that it needs to be accessible and the timeframes. So we don't force the timeframes on patients. We look at the patient from where they're at. And then we look at, well, how do we move forward together? So it's not GP in the front of Jenny or the client, it's moving forward together as equal parties. So I guess looking at culturally safe environments, what that means for your patient who comes into your practice, that needs to be included in every aspect of care. So looking into Jenny's story a bit deeper, there was the two-way engagement, and that was important. Ada, would you love to add to that?
I just want to add that you do all of this stuff in your clinical world, but the cultural side of Jenny and some people that are in my family who have mental health issues, there's always someone on the cultural side of things who's there to support people. And I think that together with your work and the cultural support that people have, the patient will marry those two together and know that they're okay, because they know that they can always fall back on the cultural side of things. And I know that's happened with my own family who have these health issues.
Thanks, Ada.
Yeah, I think, what I'd add to that too is that the reports that we hear consistently, and, this included at the round table, there were quite a few Aboriginal people at that table, so including Ada and Jacinta, but people who reported on their experience of health checks. And, and we've heard this in a lot of other settings too, where people have gone to the doctor, gone to a doctor for something, and somewhere in the middle of the consultation have realised that a health check's happening, that's just so unlikely to be of any value to the patient. And so, just thinking back on all those reasons, all the potential that health checks have to improve health outcomes, that's just so unlikely to happen if someone doesn't even know that it's happening, or they experience it as something that's been done to them. I think, Jay, you've had that experience, and there were other people at the round table that really described that. Don't know if you want to add to that.
I just think it's just beneficial to look at holistic health in a genuine way, and I think from experience as well, looking at what matters to the person in front of you. So doing the assessment comprehensively is really important, because a lot of our community members rely on the GP for some guidance, but if they're not understanding where they're heading or what they need to do to look after their health, then it can become quite challenging. So I just would suggest, if you're looking at the assessment with the Aboriginal Health Check, just take a bit of time and get to understand and build that relationship with the clients.
Yeah, Yeah. So just want to talk a little bit about what is the next slide, Daniela, what's valuable to the GP and the care team. I think I've really come to understand, I think for a lot of my clinical life, I've thought about patient engagement a lot and what we offer around establishing therapeutic, a therapeutic relationship and the sort of welcome and kindness and building trust. But I think there's also, it's more than that. I think really the engagement works when it's two-way, and what a lot of Aboriginal people, and I don't have much experience with Torres Strait Islander people, but a lot of Aboriginal people experience is non-engagement from the GP or from the practice. So I think it's really useful to think about engaging as a clinician as well as thinking about what supports patient engagement. I think also that the health check can provide a structure for organising and tracking healthcare, preventive activities, risk assessment, chronic disease management and so on. So it's a tool for organising healthcare. It supports care planning and coordination. I think when it's done well, there's all the satisfaction of making a difference, and of course there's MBS remuneration for it, including for the health check itself, also for other members in the team in follow-up items and referrals that can come from it. Is there anything you'd want to add to that, Ada?
Yeah, I just wanted to tell a story about one of my family members. I was on country when she and I was there with some medical students and doctors doing a cultural immersion, and the mental health team went to my brother's place to try and convince my niece to come to Darwin, and I was doing a bit of ear wigging, and at this stage, my niece really didn't want to come back to Darwin because she knew that when she came back to Darwin, she'd be just, on the drugs that the doctors prescribed, and she wouldn't be able to function properly. But anyway, one of the workers said to her, you're allergic to marijuana. And in that instant, I saw the light in my niece's eyes and thought, now I understand why I get sick when I smoke this stuff, And, it's about making yourself understood to your patients instead of just using your, medical words. Just make it simple so that people can understand, because not everyone speaks doctor, your language. And it's about having the two-way relationship and not just one-sided, either from your patient or from yourselves. It's about working together to make this person, a little bit better functioning in the world, but also you getting your satisfaction of seeing a good outcome. Thanks, Mary.
Yeah, thanks, Ada. So the process of review and development of these new templates, the history is that following the launch of the third edition of the National Guide to a Preventive Health Assessment for Aboriginal and Torres Strait Islander people, the department asked the college, RSCGP and NACCHO, that partnership to continue to actually review the health checks. That process was where there was broadly consultative and included a lot of people. We ran a 2-day roundtable and established a working group that included Aboriginal and Torres Strait Islander people and non-Indigenous people as clinicians, as academics, from PHNs, from Aboriginal Health Services, from the college and ACRM, from the Department of Health. There was, broad representation. It coincided with the broad MBS review that happened last year, so we were able to develop a submission to that on the 715. Yeah, it was really collaborative. It was, these new recommendations, it was very much a co-design model. So I want to just talk briefly about one of the key steps in the process of reviewing and developing the new recommendations was to identify the inclusion criteria. So what should you do when you're doing a health check? So the next slide, thanks, Daniela. So the first thing was, the first criterion was around evidence-based and identifying age-appropriate elements of a health check. And, that's pretty obvious, but it's not really what's reflected in the current MBS descriptor. So this is around, developmental, the biomedical and chronic disease risk and health behaviours, included social emotional wellbeing elements, as I described before, the population health programs and other primary care. Also elements that weren't necessarily identifying health needs that as a GP you can do a lot about, like housing, for example, but nonetheless are really important to understand the context of people's lives and health. And one of the key steps in that process was, and for identifying, evidence, it wasn't all from the literature, it was also from high quality health checks that were currently in use. So we underwent a harmonisation process with a whole stack of health checks that were currently being used, and we collected them from centres that had put a lot of thought and work into what they were including in health checks, so that they were, high quality checks. Next criterion was about acceptability and value to patients. We've talked a little bit about that already. So cultural aspects, respectful of patient priorities and goals, and in the context of trust and an established relationship with the GP and or service. We identified what we called core elements that we would recommend should always be completed, or at least that there's always a strong argument for completing them, and some extensions, although there are a whole lot more that could be completed depending on the patient-clinician relationship, on the skills and capacity of the clinician to offer services in a safe way, a culturally safe way, and there's also other factors like geographical context, things like trachoma or rheumatic heart disease that are endemic to some areas and not seen in others, and also local preferences and priorities. And the final criterion was around feasibility to deliver. So there are some differences between Aboriginal health services and, sort of mainstream general practices. and also availability of workforce and other technical requirements. And an example there would be around ear and hearing health, where there is definitely the evidence supports, for example, video otoscopy, but it's not actually practicable for all general practices to provide that. So we use this feasibility criterion to sort out some of the, whether or not something like that was included. Okay, so that resulted then, well, I'm not sure how many people are familiar with the current MBS description and explanatory notes for the health check, but currently there are 3 age bands. But a key recommendation of that came out of the working group, and actually was flagged right at the beginning at the round table, was to update elements to better reflect age-appropriate health needs, and this resulted in these 5 new templates that span the life course. So we'll have a look, we'll dive into the website and have a look. Thanks, Daniela. Hopefully not too technologically challenged here. These, as you can see, there's the 5 age bands there, available as PDF and RTF. Just really important to remember these are, example health check templates. We know that around the country where people have, locally have put in a whole lot of work, the health check template in their particular clinical software might look a little different, but these are examples of what, if it's done well, we would be pretty confident could be a useful health check. It's really important that, that these are not intended, they'll look like a sort of tick box approach, but they're not intended to promote a tick box approach to healthcare. That the intention is to prompt clinicians to think about patient priorities, to think about the opportunities for preventive healthcare and common health needs, biometric, social emotional well-being and mental health needs, and the impact of social determinants of health. Okay, so let's have a look. Daniela, let's have a look at the infants and preschool. Oh, and yeah, okay, that's all right. So they all look pretty similar. This is what the for each age group, they've all got this, what we developed as a standard sort of intro, reinforcing some of those points about what a good health check is, and a couple of the key references that inform the evidence base. So just scrolling through, we can move down, Daniela. Daniela, can you scroll down? Yeah, so there's some, I think that was a freeze. So it starts with some biographic details and details about other people, other services involved in care and support, and the details around consent, which are really important, and like in that the case that we just mentioned, aren't always attended to. And then if we go through, and I just encourage people to, do this at your leisure, but there's a whole lot of age appropriate assessments. If you can, it might have frozen. Okay. And this in the infant, and this is infants of birth to 5 years, infants and preschoolers. We've included a developmental screening tool, which was developed by the Health Department in Queensland, and it's called the Red Flags tool. We actually, if we get the chance to have a look at it, you'll notice it's really flagging milestones that children don't reach. And if you're able to scroll, Daniela, it might have frozen. One of our principles that we work to is around being strengths-based, and we actually rejigged this, the Red Flags tool, to make it strengths-based. So that was really about thinking about milestones that children would reach rather than the milestones that they haven't reached. But when we approached the Department of Health in Queensland, we didn't get permission to use our rejigged version. Okay, just still a bit further down. Yeah, so that's the Red Flags developmental screening tool. Okay, so then there's just a whole lot of other elements that you'll see: checking that immunisations are up to date, some basic sort of biometrics, and then the final part of their health check, which has got the looks the same in all of the health checks, that really reinforces the principles that we've tried to emphasise in our recommendations, and that's about patient priorities and goals, everything that's been provided in the health check, health advice and information, and specific care like immunisations or medication review, investigations that have been ordered. Importantly, like new diagnoses and other assessment and the planning that comes out of that. And this list of which we developed for each health check in an age-appropriate way around the likely clinicians and services that you would refer to. So the primary team, the GP, Aboriginal health worker or health practitioner and nurse, but then any referrals that would come out of the health check. So we might just have a quick look at another one, at the older persons one, Daniela. So again, this will look pretty similar. In the beginning, if you can scroll through it, Daniela, just to one of the key, if we get the chance just to show you, so some prompts about the sorts of things that you would consider screening for or checking up on for an older person, and it looks like they're slightly defeated by the technology. So we can go on to the next slide, Daniela. Thanks. So yeah, just really, encourage you to have a look at those. Think about, compare them to the templates that are in the clinical software that you use, because all the major providers have got a 715 template. They're pretty variable. Think about local modifications that you might want to make, might want to include or delete from your health check. And I can give some examples of that. There's I know I'm involved in another project around dementia and cognitive impairment, and there are some we've done audits in services where an MMSE is included in a 715, and that's not a good evidence-based screening tool, as an example. But in our template for older people, we've included what are much more evidence-based questions as screening questions around cognition. There's lots of examples of that. Okay, so just to revisit the finalising the health check, because this was I think that the feeling from the working group was that, you know, this was quite a paradigm shift to be building into recommendations for the health check, a lot of guidance around what would support engagement in ongoing healthcare, which is actually where the health benefits will come from. Jacinta, do you want to add to that?
No, I just agree with what you're saying at the moment around the patient priorities and looking at the goals. I think that we need to, you know, look at what the follow-up looks like as well, because, you know, from experience, when people have completed their health checks, the follow-up doesn't occur in some situations. And again, I refer to that's where people falling through the gap is because we're not picking up that extra support that they might need within the community. Ada, would you like to add any more to that?
Oh, no, I haven't got anything to add. Thanks.
Yeah, and you know, there's a whole lot of, you'd love to do some good research on this, on what really makes a difference. I mean, a lot of our recommendations, they were built on broad consultation and input from people, but you can see there's lots of really good research questions that could be teased out to really sort of nail what makes a difference, what really supports engagement and people to feel connected to their healthcare and where the health check sits in all of that. Okay. Yeah, so I just want to go through a few of the pitfalls, Jay. Were you going to talk about that one, Jay, about engagement and trust, which is, you know, what we've, and the experience of doing of having a poor health check can really put people off coming back.
Jay might have frozen. I think her video's frozen.
Oh, right, yeah, yeah. I guess that one, that, you know, that's what we've talked a lot about in our previous 2 webinars. The quality of health check is really highly variable, and we would encourage people, as in, you know, unless you're very confident about the health check that is in your current software, to you know, to use evidence-based and high quality templates. So I encourage you to look at those ones we've just had a quick peek at tonight. There's a real risk of pushing through for quantity over quality, and there's always a risk in a fairly well remunerated MBS item that that can override the quality and the commitment to health outcomes. I think, and this next one about, you know, that health checks aren't proxy for all preventive healthcare, you know, that's important for practice teams to really understand that. And I mean, I think, you know, we know that as GPs and clinicians, but that's also a really important message to policymakers, because there can be a really big push to measure the number of health checks and see that as proxy for the delivery of comprehensive primary health care, where a health check is probably better thought of as a welcome mat or something like that, rather than, you know, comprehensive primary health care. Yeah, and we've talked about follow-up there's just, you know, on its own, a health check isn't going to produce better health outcomes. It really is about, you know, evidence-based treatment of conditions that are assessed and all the follow-up things that are put in place. I think a recent review of Aboriginal and Torres Strait Island people, a study on cardiovascular treatment, I think found that 40% of people were not on recommended medications. So there's just enormous opportunity once you know about it to really influence health outcomes. And Ada, impact of racism and cultural stereotyping.
I just wanted to go back to the first point and just add a little bit extra to what you said. You know, it's about putting yourself in your patient's shoes and thinking about what do you want out of your consultation, you know? Like our people may not ask many questions, but they put their trust in you. And, you know, when we have things that aren't going right for us, we're always asking questions about, you know, why did this happen? Why did that happen? But I might not be able to articulate in the way that you understand. So if you could put yourself in your patient's shoes and just think about it in that way, and what best for you if you're sick, you know. With the impact of racism, you know, your clinic might look inviting to an Aboriginal person, but what's behind those closed doors, or what's at the reception, and what sort of reception we get from you and your staff is the thing that makes or breaks the consult with your patient, you know. And you have to remember here again, you know, to speak to someone how you'd like to be spoken to is a good way to start. And for me personally, when I leave my house in the morning, I don't know what's out there, you know, in the form of racism, because I live with it every day of my life. Even though I don't want it to impact on my life, but there are some days where you know, these things happen. Some days I have the energy to fight, some days I don't. And, you know, most of the time speaking to my family and friends and that, you know, I think we've learned how to pick our fights. And this happened to me just the other day, where I was going home from work and I went to the local shop, and I was asked for proof of my address because I was buying alcohol. And, you know, who carries around proof of their address unless you've got a driver's license? I don't drive, so I don't have that, you know. And, you know, yesterday I had the fight in me. Maybe tonight I won't, when I go, you know, walk home from here to my place, which is about 20 minutes away. But, you know, it sits at the forefront of your mind all the time, because no one doesn't look at me as Ada Parry, this woman that goes to work, you know, and earns her crust in this country. They look at me as this black old woman walking down the street, and how they're going to speak to me. But it's already, you know, their minds are already made up. And people say Darwin is a multicultural city. But, you know, I don't let it hang over my head like a lot of my countrymen, but it's just there that, you know, you have to be mindful about how you speak to people. And, you know, if the shoe was on the other foot, how would you react to something that that's said to you? You know, like, you know, lots of stories that I've heard over the years and still happening today, like even when people go into a shop and they're being followed around, you know, that sort of stuff. It's crippling, but somehow we just get on in this world and make the best of it. And, you know, we're not supposed to react to the way people speak to us, but, you know, it's just something that lives with us. Thanks, Mary.
Yeah. And Ada, you know, just in our preparation for this, you know, a couple of things that just I want to share. One is that reflecting on these 3 webinars around cultural safety, and I've, you know, worked for decades in Aboriginal communities and thought a lot about cultural safety, and there was, but even so in our conversations in the last few days, I was really hit with, it's not just about cultural safety in healthcare. Actually, what you describe is not being culturally safe walking down the street, and so that's one thing. And then another was that we know that a lot of the you attendees, participants in this webinar, just looking at people's names, that it's, and some of the feedback that we've had, you know, there's probably, well, there's a lot of ethnic diversity, and, you know, we were sort of reflecting on that probably some of you as participants experience and can relate to, you know, racism and discrimination. But I think, you know, and so really acknowledging that. And there's a particular indignity about experiencing that in one's own ancestral land.
I don't know if you have seen that ad. It used to be on all the time about racism and, you know, getting on the bus. And the Aboriginal person is always left with, you know, 2 seats to themselves. Well, hey, yeah, I love that. I don't want anyone sitting next to me crowding my space on the bus.
Yeah. All right, we better move on. We're nearly out of time. So just the really key messages, if there are sort of 2 main messages, it's, you know, around the health check and the value of them. It's around patient-centeredness and continuity of care. And as we finish these webinars, a final plug for the resource hub on the RACGP, the college website, which is the NACCHO RACGP resource hub. And there's a whole host of resources there to support you as GPs and your practices to provide culturally safe healthcare for Aboriginal and Torres Strait Islander people. We are out of time for questions, but maybe there's time for people to, there's a couple of slides of useful resources, but there's definitely time for people to post some questions, which we are really happy to respond to. Daniela, do you think
we've got 1 minute left. We can sneak in one question. We did get some questions through, so we'll make sure that we do compile those in the fact sheet for everyone. But I guess engagement being so important, this question comes through about to get engagement, we need to get informed consent in the first place. How do we know we have informed consent? What are the signs?
Well, I think that's a generic question really for a clinician. It's always our job to to interact with people in a way that is consensual. I think that's the basic therapeutic contract. And in that sense, that I would say that there's no specific difference. Okay, in principle, there's nothing particular about Aboriginal and Torres Strait Islander people, but to get engagement and to establish trust, which is where real consent comes from, and then providing accurate information that is appropriate and that is understood, and checking understanding is a key part of consent. I think that's sort of all the things that we've been talking about over these 3 webinars, which is around cultural safety and around, welcoming and hospitality and kindness, and cultural advocacy, as well as high clinical standards. Yeah.
And as long as you know that I understand as your patient what you've said to me,
And thank you, Ada, Mary, and Jacinta, who unfortunately we lost at the end there. Thank you all for a great webinar and for your participation, and have a great night, everybody. Thank you very much.
Thanks, everyone.
Thank you.